Today we are going to discuss how do we start the initial antibiotic therapy for patients who get admitted to the ICU. It is a very important topic, and after doing my post graduation in anesthesia, when I entered ICU training, that was the most difficult question I used to face in day to day circumstances. And many times I would shy away from the point where I need to prescribe new antibiotic for a patient, and I would try to seek help to discuss with various colleagues, seniors, and get some idea about how to approach this issue. Uh, if I were to take an educated guess, probably I would say cefoperazone sulbactam or piperacillin tazobactam. They are the first line agents that I would choose for a patient getting admitted to the ICU. Partially, that answer was correct, but if you think in more detail, when I read more, when I had more experience, that expanded my horizons, and I could think more clearly and in more efficient way, and I could see what all options I had, and piperacillin tazobactam or cefoperazone sulbactam are not the only options that I had for my patients in the ICU. So in this discussion, we are going to discuss about the various aspects to consider before we start antibiotics to a new ICU admission. I learned these new concepts since my training, and I have evolved in terms of understanding and have reached this stage. So I really hope that that is useful to you as well. This lecture, we are focusing just on initiation of antibiotics. We are not going to discuss what happens further or how do you interpret cultures, when to stop antibiotics. Those are the topics which we can discuss in further videos on the same series. So I'm going to discuss this topic under following headings. If you find these headings helpful or useful, I'm going to elaborate each of them in detail. So if you like them, you can continue watching the video. If you find they are not useful, you can stop after hearing the headings. So first question we need to ask is, am I suspecting infection for this patient? Second question is, could it be viral, fungal, or protozoal infection, or it is going to be bacterial infection only? Next thing is, what are the other tests like WBC or inflammatory markers? What are they showing and indicating? We will also discuss about appropriate cultures. We will discuss about the patients coming from community versus patients having hospital exposure and what all factors to consider. We will discuss about the resistance pattern amongst the organisms for various antibiotics. We will discuss the use of previous cultures or previous tests in recent past. We will also discuss the risk factors for developing multi-drug resistance infections, which might be very useful. Uh, we will discuss about while we select the antibiotic, what all things we need to consider, starting from allergy, side effect to the site of action, pharmacokinetic, pharmacodynamic dynamic dosing of various antibiotics. And we will discuss about surgical source control. At what point should we consider involving an infectious disease specialist? What is the role of microbiologist in these discussions? So these are the headings, and we are going to discuss all these headings in further details. So not wasting your time further, let's start with the first question. Am I suspecting infection here? For your patient who is admitted, and obviously to get the answer, you are smart enough, you should just apply your brain, spare few moments, and you will get answer. What kind of symptoms does the patient have? If the patient is presented with fever, may have chills and rigors as well, that is a sign of infection for sure in most circumstances. If the Now, depending on the various systems involved, the infection could be in the starting from the brain. For example, it could be meningitis, encephalitis, it could be upper respiratory tract infection, it could be lower respiratory tract infection, it could be endocarditis, it could be intra-abdominal infection, pyelonephritis, or UTI lower down the track, uh, bone infections, skin and soft tissue infections, surgical site infections. So various infections would have various symptoms, and you need to use some common sense to really determine how to get answer of this question. So patient may have cough, may have sore throat, may have sputum production, purulent sputum, which will guide you towards the possibility of infection. For UTI, patient may have burning micturition. For cellulitis, patient may have redness, swelling. Sometimes patient may have purulent discharge from wounds. For Abdominal infections, patient may have abdominal pain, loose motions, dysentery, vomiting sometimes. There could be joint infections, so patient may have swollen tender joints, restriction of movement of the particular joint. For CNS infection, patient may have altered sensorium or drowsiness or even seizures. So these are the common, I would say, infections. For endocarditis, patient may present with a new murmur, which was not present in the past examinations, or there is no significant history of that. Also, an important thing to notice here is elderly patients not only present with symptoms related to their site of infection, they also have confusion or drowsiness or sometimes even loss of consciousness when they have an infection. So that needs to be, so elderly patient with confusion or altered sensorium, we should think that whether this patient is having a new infection. Patients with neurological diseases like Parkinson's disease or dementia, for example, their diseases, their manifestation of the neurological disease becomes worse. They become more rigid, more stiff, and that could be because of an underlying infection. So we need to know this as well. Second question that we are going to discuss is it bacterial infection or could it be viral or fungal or protozoal infection? Protozoal infection, sorry. So for that, we need to see the presentation, and based on that, we can make a guess about what kind of infection it is. So fungal infections, for example, are not common in immunocompetent patients. So if your patient has a background of immunosuppressed condition, advanced uncontrolled diabetes, steroids, chemotherapy, solid organ or bone marrow transplant recipients, these are the patients where you would think of fungal infections or certain viral infections. Patients coming from endemic areas, so coming from certain areas, you would think about certain infections. For example, tropical diseases, so dengue, malaria, leptospirosis, amoebiasis. These are the diseases which are endemic in certain areas, and if patient comes with those symptoms, you need to parallelly think that it could not be bacterial, it could be one of these infections. If there is ongoing epidemic in the area from where patient is coming, like for example Ebola, COVID recently, or swine flu, that could be the presentation for the particular infection, the endemic disease, the epidemic disease. Also, history of any pets at home is useful. So history of exposure to parrots is associated with psittacosis, history of exposure to cat associated with toxoplasma, patient's occupation, so farmers associated with brucella or leptospirosis, patients who handle the hides of dead animals, association with anthrax, fishermen association with vibrio. So these are the occupational exposures. IV drug abusers can have right-sided heart endocarditis. So that is something which we need to suspect when we see these patients. The next thing is look at the blood test and inflammatory markers. So generally your patients, if they are having a bacterial infection, they will have elevated WBC count and elevated neutrophils. Sometimes a very sick patient may have neutropenia or leukopenia as well. Generally, patients with viral infection have higher lymphocyte counts rather than neutrophil counts. These are not very diagnostic things, but they are, if you take a collective picture with all the information that we are discussing, you might be able to come to some conclusion. If you send the CRP and it is elevated, that indicates that there is an ongoing inflammatory process, and it could very well be infection. Use of procalcitonin can also sometimes, if it is very high, you could suspect that it is bacterial infection. You need to know about the limitations of procalcitonin as well. And if you look at the evidence for procal says that it is best used to stop antibiotics for community acquired or sometimes hospital acquired pneumonia. And all the other uses are extrapolation from the evidence that we have gathered. If you want to know more in detail about the procalcitonin and its application, please check out my video on procalcitonin. Now, next point I want to discuss is cultures. So, in all the patients who present with high fever or other systemic signs, it is a very good practice to send blood cultures, especially when they come to ICU. You may not send blood cultures for each and every fever in the ward or at home, but if they need to come to ICU for intensive monitoring or organ support, it's a good idea to send blood cultures. We send at least 2 cultures, each being 10 ml or more. Don't send cultures from the peripheral or central lines which are already there. They would not represent the bloodstream infection. You can send a separate culture from central line if it's already there in place for more than 48 hours, but that is a different thing. Okay, patients, especially who are immunosuppressed patients or patients with COVID or influenza, you can send upper respiratory or lower respiratory PCR panels which detect various diseases, viral and bacterial included. Viral mainly for the upper respiratory and bacterial mainly for the lower respiratory tract. So you could use them, the PCR test, to quickly give you a result and give you some idea regarding the direction in which you need to go. If the patient is producing purulent sputum, you can send the sputum for culture and microscopy. If you have intubated the patient, you can send tracheal secretions or bronchoalveolar lavage to detect for any growth and colonies of various infection. If urine is your suspected site of infection, you should send urine routine micro and microscopy and culture sensitivity, of course. If CNS meninges is your site of suspicion, rule out raised intracranial pressure, and then you should do a lumbar puncture, do a CSF, do all the routine and cell counts and culture as well. You can also do a PCR for CSF, which will give you some more information. If there is a pus discharging sinus or wound with pus discharge, it is a good idea to send that pus as a swab for the cultures. Generally, if there is no pus discharge and there is a dirty wound and you send a wound swab, it is not a good quality culture sample, and it could be contaminated with various infections. So it could give you false results and multiple infection could be detected. So please be aware of that. That wound culture generally, the swabs are not considered good source of sample. Uh, if there are deep-seated infections, intra-abdominal or joint infections, it would be a good idea to do a radiology-guided aspiration. This could be ultrasound or CT-guided aspiration of the pus from various loculations. Another important thing that I want you to know is timing of fever with cultures need not be emphasized upon. If the patient is febrile and you take blood cultures, that's fine. But if the patient is not febrile, don't wait for the patient to have the next spike of fever so that you can take cultures. You take cultures as early as possible. This is also because you need to start antibiotics as early as possible. So second important point here is don't delay your antibiotic for the sake of taking cultures. So if there is some reason for which you cannot take cultures, say you don't have culture bottles or you don't have the sample collection containers, don't delay your culture antibiotics, because each hour delay in administration of antibiotics in the patient's in septic shock leads to 5% increase in mortality, which is a significant number. So, and generally, if the site of infection, if the sample is taken from, say, sputum or urine or CSF, an interval of up to 2 to 4 hours would not really make a difference. It would not really make your culture negative. So, bear that in mind and don't delay the first dose of antibiotics for sake of cultures. Now, let's discuss whether your patient has come from community or hospital, and how does that affect your decision to start antibiotics. So obviously, as a general rule, the patient coming from community are likely to be infected with susceptible organisms. Patients having hospital exposure in last 3 months are likely to be infected with resistant kind of organism. So that is the implication here. You need to also be aware of the area of your practice. What kind of antibiotic resistance is prevalent in the community? What kind of antibiotic resistance in your hospital? And what are the common organisms seen in your hospital? So you need to know your antibiogram of the hospital to take a better, more judged decision while you start the new antibiotic. Some patients have history of hospitalization or hospital visits in the previous 3 months, and they would have undergone any screening swab, or they would have some cultures taken, and they would have grown something, or it would have detected some organism. So it is always a good idea to look at these all isolations, and these patients are likely to have a full blown infection with the colonization that was detected in the past. So always look at the previous cultures and screening swab, especially in the last 3 months. So now, what are the risk factors for multi-drug resistant organisms? So, for example, for let's say MDR pneumonia. So the patients who have previous hospitalization in the last 90 days, patients who have received antibiotics for more than 2 days in the last 90 days, patients with COPD, diabetics, or patients on steroid, immunosuppressed patients, or patients with previous colonizations with multi-drug resistant organisms, they are likely to suffer from the MDROs. Patients are also likely to suffer for certain group is likely to suffer from MRSA. This group includes patients who live in a very congested accommodations, army recruits, contact sportsmen, men who have sexual intercourse with other men, some dialysis patients or chronic wound care patients. These are likely to suffer from MRSA infections. So when these patients visit you, you should suspect whether there is an MDRO or whether there is an MRSA, whether that possibility is there, and your initial antibiotic should choice should reflect that. Now we will discuss certain points about the antibiotics in particular. So to start any antibiotic, you need to think what is the site of infection first of all. So why you need to know that? Because certain antibiotics have good penetration in certain tissues, certain antibiotics don't work in certain conditions, and it is important to know this. So say for example, fluoroquinolones have very good concentration in the prostate. So if you are suspecting prostatitis, fluoroquinolone is a good antibiotic choice. Aminoglycosides do not penetrate the abscesses well. So if there is a suspicion of abscess, starting aminoglycoside would not be very helpful. Certain antibiotics, say daptomycin, is inactivated by the surfactant in the lungs. So for pneumonia or lung infections, daptomycin is not considered a good antibiotic. Certain antibiotics have various penetration across the blood-brain barrier. So if you are suspecting meningitis or brain abscess, you need to choose your antibiotics accordingly. So for example, antibiotics with good CSF penetration, they include your fluoroquinolones, trimethoprim, sulfamethoxazole, metronidazole, chloramphenicol, fosfomycin. Uh, in terms of antifungals, you can use fluconazole and voriconazole. In terms of anti-tubercular drugs, you can use isoniazid and pyrazinamide. Remember that rifampicin and ethambutol do not penetrate the CSF well, but if the meninges are inflamed, they can penetrate the CSF. Similarly, when the meninges are inflamed, your glycopeptides like vancomycin and teicoplanin and azithromycin can also penetrate, but not routinely. Certain antibiotics have poor penetration across the blood-brain barrier, and these include the beta-lactam antibiotics, aminoglycoside, tetracyclines, clindamycin, daptomycin, colistin. So, for beta-lactams, for example, when we use it for CNS infections, we tend to give higher dose, generally double the dose that we would use for any other site of infection. So we need to know that. In terms of antifungal, Itra and posaconazole have poor CSF penetration. Echinocandins and amphotericin B also do not have great CSF penetration. So that is important to know. You should also be aware about the allergy that the patient might have for certain antibiotics. It is very common in our practice for the patients to say that they are allergic to penicillins or sulfa drugs. So the second important question you need to ask is what kind of allergic reaction they have had and what treatment did they require. Sometimes the reaction they say is just feeling unwell or very non-specific symptoms. So you could very well exclude that as an allergy, and you could still go ahead with the desired antibiotic. You should also know the pharmacokinetic and pharmacodynamics of your antibiotics, whether your antibiotic is lipophilic or hydrophilic, whether they have large volume of distribution. These things are important to know. In terms of pharmacokinetics, certain antibiotics work best when they have concentration higher than the MIC for a longer time. Certain antibiotics work best when they have very high concentration, even for a short duration of time. So they follow various pharmacokinetic principles. For example, the beta-lactams, carbapenems, they follow the time more than MIC. So they have to be given in the form of infusions, generally over 3 hours each, which will improve their effect. Aminoglycosides, on the other hand, are associated with concentration more than the MIC. So their concentration has to be a high concentration has to be reached for them to be effective. Medicines like colistin, they follow area under the curve more than MIC. So they follow a different pharmacokinetic, and they require high loading dose followed by regular intervals of dosing. So that is important to know. The next thing is route of antibiotics. So in most of the patients for ICU, to start with, you would mostly start with intravenous route. But as the patient gets better, you could continue the same antibiotic and switch it to oral. So for that, you need to know what kind of bioavailability is there for your individual antibiotics. So fluoroquinolones, trimethoprim, sulfamethoxazole, metronidazole, clindamycin, doxycycline, minocycline, they have very good bioavailability, and their oral and IV doses are generally interchangeable. You need to also think about the loading dose that you are going to give. So sometimes the patient has a background of CKD. Sometimes the patient has come with acute kidney injury, and sometimes the patient has liver dysfunction. So all these things need to be considered when you decide about the loading dose of your antibiotic. In general, if we say loading dose should be the full dose that is to be given, because you want to reach the therapeutic concentration with your first or your loading dose. And generally the patients with sepsis have hyperdynamic circulation. Their kidneys also receive more blood supply because of this, and the renal clearance of antibiotics is also higher in the first 1 or 2 days of sepsis. So that is called augmented renal clearance. And keeping that in mind, we, even if there is some kidney impairment, we tend to give full loading dose for antibiotics, sometimes even higher than the normal dose advised. So keep that in mind. Further doses can be adjusted according to the renal clearance or the liver function. And generally, I use Medscape, which is a very good tool to determine the dose adjustment for various antibiotics and antifungal medications. So that's about the loading and maintenance doses. Now, you should also know the concept of therapeutic drug monitoring. So there are certain antibiotics which, for which we monitor their peak levels and trough levels, or just the trough levels, to decide whether when to give the next dose and whether to change the dose further. And we can do that for gentamicin, tobramycin, teicoplanin, vancomycin, daptomycin, chloramphenicol. We can do that for azoles, linezolids, doxycycline. So you need to find out in your center or near your area of practice what all therapeutic drug monitoring is available for various antibiotics, and you should try and take advantage of that so you can optimize your dosing for your antibiotics. Another important thing to discuss is the surgical source control. So sometimes just starting appropriate antibiotics is not enough. You need to do surgical intervention, for example, for necrotizing fasciitis or intra-abdominal collection, empyema, or joint infections. So you have to surgically drain or do debridement for the patient, and ideally this should be done within 12 hours of admission. And so you start your appropriate antibiotic, refer to the surgeons as necessary, and try and get the surgical source control also as soon as possible, because otherwise your patient is not likely to improve, and you may end up with a even worse patient, or may even lose your patient. Last few things. So it is always a good practice to discuss with your microbiologist on a routine, at least daily or alternate day, and always for a new patient have a discussion, review with the cultures and other reports, susceptibility test, procal, CRP, everything, and your clinical impression. Review them again with your microbiologist after a day or two, and that will be really helpful for you to determine whether you are giving the correct antibiotic or you need to change. When do you consult infectious disease specialist? Infectious disease specialist is a very useful branch, and the thing that I have noticed is they have lot more things on their plate, and practically you cannot involve them in each and every case. But you should definitely consider infectious disease specialist referral when you are dealing with complex patients, patients with multiple problems, multi-organ involvement, or when your initial antibiotic therapy has not worked, or you are not able to see the desired result. Don't hesitate and call your ID specialist colleague and take their opinion, because they are trained in this particular field, and they could really make things easier, or sometimes give you some out of the box solution which might help you tide over the crisis. So that's about the topic for today, and I hope you have liked this video. Till we meet next time, bye bye.